Thank you for joining us for the case-based review course in Neuroradiology at RSNA 2020. I'm the course director, Amy Giuliano. On behalf of the RSNA Educational Committee and our track chair, Dr. Ricardo Restrepo of Nicklaus Children's Hospital in Miami, welcome to this session. For this first of our 2 sessions, we have a focus on pediatric neuroradiology, and we have a great slate of speakers lined up. We have Dr. Huseman of Texas Children's Hospital, Dr. Al-Rayahi of Sidra Medicine in Doha, Qatar, and Dr. Torres of University of Ottawa, who will show us a wonderful variety of cases. I try to pitch in with head and neck, and I work at Massachusetts Eye and Ear Infirmary in Boston. As a quick reminder, please mark your calendars for tomorrow afternoon for our second session on adult neuroradiology and neuro-IR. And now, without further ado, let's get it started.
Ladies and gentlemen, it's such a pleasure to me to share the next 50 minutes together with you and to brainstorm about the pediatric brain. Nothing to disclose and nothing is interfering with my presentation. I would like to thank Amy Giuliano, who is the chair of the Neuroradiology section of the case-based review course at RSNA. She gave me the task by email as follows. I think the audiences appreciate seeing more cases with a brief, concise explanation of imaging features rather than only a few with drawn-out explanation. So I'm going to show you 10 cases in 15 minutes. I also would like to emphasize again that we all know you will recognize what you're familiar with or what you expect to see. If you don't expect the unexpected, you will not recognize it when it arrives. You should not forget this. For example, this case I got many years ago from Dr. Anna Neidecker. This is a case of a patient who was suffering apparently from back pain and a wobbly gait. This looks very confusing. The cervical spinal cord and the vertebral column looks very hyperlordotic. So this is confusing to you because this is a penguin and this is apparently the normal anatomy and you were confused because it was something you had not seen before, or most likely not seen before. So I'm going to show you many ONT minis. Now, you will all be familiar with ONT mini, but what is the exact origin of the term ONT mini is a bit hazy and is believed to date back to 1940s, where Dr. Ben Felsen, a radiologist from Cincinnati, said the following. An ONT mini is a case with imaging findings so specific and compelling that there is basically no differential diagnosis. Or, if it looks like your ONT mini, it must be ONT mini. So this year, I would like to focus on ONT minis in the field of pediatric brain malformations. So let's go to the real first case. Sagittal T1 and coronal T1, as well as color code and non-color code FA maps of this patient. And you see, something is wrong with the corpus callosum. The anterior part is present, the posterior part is present. And then you see some gray matter in the midline where you expect to see the corpus of the corpus callosum, or the body. And on the FA map, you see some white matter tracks, most likely which are crossing from left to right here. It's very deficient. So what is a differential diagnosis? Is it a corpus callosum agenesis, a corpus callosum lipoma, an alobar holoprosencephaly, or a syntencephaly? This is a syntencephaly, which is known as the middle interhemispheric variant of holoprosencephaly. The anterior and posterior interhemispheric fissure and the forks are present, but there's a non-separation of the most posterior frontal and the most anterior parietal hemispheres. And typically you will see gray matter along the superior contour of the non-separated mid part of the lateral ventricles. The forebrain, the anterior frontal lobes, occipital lobes are typically well separated. You have a normal genu and splenium of the corpus callosum, while the body, as mentioned before, is absent. And you have a normal midline separation of the basal ganglia, thalami, and hypothalamus. You may see additional information like KI1 or KI2. Next case. A fetal T2-weighted MRI sagittal plane and the matching postnatal T2-weighted MRI. We see tubular T2 hypointense structure in the midline superior to the vermis, confirmed in postnatal imaging. The postnatal Ultrasound imaging, including color-coded duplex sonography, show an hypoechogenicity of this lesion with exquisite turbulent flow within this lesion. Now, what is this? A vein of gallon aneurysmal malformation, a giant basilar artery aneurysm, a cavernoma, or a teratoma. This is a vein of gallon aneurysmal malformation. This is a congenital midline vascular anomaly with a lot of AV fistulae involving the vein of Galen. The vein of Galen will consequently be enlarged or dilated. It is easily identified on prenatal and postnatal ultrasound, as well as on color-coded Doppler sonography, but also, of course, in MRI and MRA. You can see a supratentorial ventricular megaly due to the compression of the tactile plate by the dilated vein of Galen, but also secondary to an arterial pressure within the dural sinuses secondary to the AV fistulization. The increased intravenous pressure may impact the normal resorption of CSF into the pachyonic granulations and the superficial venous system with consequent hydrocephalus. Next case, fetal and postnatal imaging. On the T2-weight imaging, on the fetal MRI, you see that basically the entire cranial vault, the supratentorial space, is filled with fluid, T2 hypertense fluid. We see some residual thalami, maybe a little bit of basal ganglia, and a relatively normal paying vermis, as well as brain stem. This is, of course, confirmed on the postnatal imaging. So is this a congenital aqueductal stenosis, resulting in high-grade hydrocephalus? Is this a gliomatosis cerebri? Is it T2 hyperintensity? Is it hydrancephaly? Or is it a very severe post-infectious cystic leukomalacia? This is a classical hydrancephaly, where you see a complete or near complete absence of the supratentorial brain, and we believe this is secondary to an occlusion intrauterine or complete atresia of the supraclinoid internal choroid arteries. The brainstem, cerebellum, and thalami and the choroid plexi, which are supplied by the posterior circulation, are typically intact or at least partially intact. Also, part of the basal ganglia and the most mesial or medial occipital lobes may be preserved because they are perfused over the posterior circulation. The falx cerebri is present but may be partially ruptured. You may see some residual leptomeninges along the inner tablet of the skull. You should not see the normal circle of Willis, in particular not the supraclinoid internal choroid arteries. And you should be aware, of course, the entire supratentorial brain is replaced by cerebrospinal fluid, and this may result in significant ventriculomegaly or basically too large head. We call it ventriculomegaly because it is most likely still a kind of widened dysplastic ventricular system, and for that reason, in rare cases, you have to shunt it because a big head makes it almost impossible to take care of those children who barely move, resulting in injury to basically the skull and the skin. Number 5, T2, T1 with contrast, diffusion, and ADC map. What do we see? We see a partial widening of the parapontine or cerebellopontine angle. We also see a little displacement of the trigeminal nerve, but we don't see a real lesion over here. It is an iso-intense to CSF widening. But on the diffusion rate imaging, we see focal area of restricted diffusion, DWI hyperintense, ADC dark, surrounded by the cerebrospinal fluid. What's the diagnosis? Is this an epidermoid, an arachnoid cyst, an acoustic neuroma, or a lipoma? This is an epidermoid. Epidermoids are mass-like lesions consisting of epidermal tissue ectopically located within the cranial vault or even spinal canal. They can be congenital due to anomalous inclusion of ectodermal cutaneous cells during the development, but they may also be secondary, acquired. For example, after neurosurgical procedure, with an iatrogenic inclusion of the squamous epithelium in the neuroaxis. And they have a slow growth because you have an ongoing epithelial desquamation and keratin accumulation, like you would have with normal skin. But of course, it is not having the possibility to be the relief from this location. That's why it grows. It's most frequently located within the subarachnoid space and typically in the basal cisterns. They have the same density of cerebrospinal fluid on conventional T1 and T2 radial imaging, difficult to recognize, but because of the consistency, they typically have restricted diffusion. That's why you easily see it on diffusion radial imaging. Next case, fetal and postnatal, high-grade hydrocephalus. High-grade hydrocephalus, a funny-looking cerebellum, or basically it's just one big blob of tissue, and we see gray matter in the midline. So what is this? Is this a Denny Walker malformation, a Joubert syndrome, a rhombencephalosynapsis, or a tactile glioma resulting in this high-grade hydrocephalus? This is a rhombencephalosynapsis. We have a complete or near complete lack of development of the vermis with a fusion of both cerebellar hemispheres. Also, the dentate nuclei will be fused as well as the middle cerebellar peduncle. The cerebellar foliae and fissures will extend uninterrupted across the midline because there is no vermis. On sagittal imaging, you will not see the normal verminectomy, but you see the cerebellar hemispheric anatomy, and you see typically gray matter in the midline due to the fusion of the dentate nuclei. The fourth ventricle is typically small, and you have usually a moderate to severe supratentorial ventricular megaly. Rhombencephalosynapsis may be isolated, but may be also part of a syndrome, the typical Gomez-Lopez-Hernandez syndrome. We have, in addition to the findings of rhombencephalosynapsis, a developmental delay, scalp alopecia, and the trigeminal anesthesia. Next case, two cases, an MRI and the CT. You see here some kind of a vascular structure sitting on this MRI superior to the area of the superior sagittal sinus, and it appears to go through the skull. In this other case also, it appears to be a defect in the skull allowing vessels to extend in the subcutaneous tissue. Is this an atretic encephalocele, an anomalous delphine sinus, a virtual, like virtual meetings, virtual venous drainage, or a sinus periacrani? This is a sinus periacrani, where you have a varicose subcutaneous collection of calvarial veins that communicate through an opening in the skull with the adjacent dural sinus and typically the superior sagittal sinus. This extension goes over the emissary veins. They may dilate, and if they dilate, they may result in a slow, progressive widening of this defect on the skull. Typically low pressure, slow venous flow, and a typically midline or a very close proximity to the superior sagittal sinus. Clinically, soft focal scalp swelling, and you can easily compress it. And occasionally you will see intracranially, intraaxially, a developmental venous anomaly. Next case. T2 axial, coronal T2, sagittal T2, and a color-coded FA map. A very funny-looking right hemisphere. The whole right brain half looks bigger. The cortical ribbon is ill-defined, very shallow, almost no sulci. The ipsilateral lateral ventricle is widened. The midline somewhat preserved. Now what is this? Is it secondary to a herpes simplex virus infection? Is it a hemimegancephaly, toriscephaly, or a gliomatosis cerebri? This is a hemimegancephaly, characterized as a diffuse hamartose overgrowth of part or the entirety of the cerebral hemisphere. The cortical ribbon is thickened, dysmorphic, simplified gyration shallow sulci, and typically you have an anomalous or an abnormal annihilation of the adjacent white matter. The ipsilateral lateral ventricle is typically wider than on the contralateral side, most likely commensurate with the enlarged cerebral hemisphere. Midline, as mentioned before, is usually preserved, but the skull on the side of the affected hemisphere is usually bigger. Children may present with intractable seizures, developmental delay, and hemiplegia. And hemimegancephaly may be isolated but also be part of syndromes, for example, Klippel-Treonnet or Proteus syndrome. Next case. T2 axial, sagittal T1, coronal T1. Funny looking brainstem, a little bit like a butterfly. Very funny dysmorphic basal ganglia, basically no anterior internal capsule. And somewhat dysmorphic ventricular system, also the brainstem looks awkward. So what is this? Is this an ileopathy, an apathy, tubulopathy, or a sympathy? This is a tubulopathy. Tubulopathy is a secondary to mutations of the tuba A, B, or G genes. These genes encode for the isotypes of tubulin, and tubulins are proteins that are the components of the microtubules. So the microtubules, the microtubule skeleton, cytoskeleton, is essential for normal brain development. And if this is abnormal, a lot can go wrong in the brain, a lot. You see them listed over here: corpus callosum, cortical malformations, etc., etc. But typically, you will see that the anterior basal ganglia are dysmorphic and rounded, and that the anterior internal limb of the internal capsule is lacking or barely visible, resulting in this dysmorphia. Last case. Two cases here next to each other. We see here a sagittal and axial T2 weighted image and the color code of AMAP. A big bump here dorsally to the pons, and the anterior pontine belly is shallow. And we see here an abnormal appearance of the transverse pontine fibers. We see some transverse pontine fibers or fibers in the area of this bump. Now, what is this? A pontine duplication dysplasia, a pontine tegmental callus dysplasia, a pontine tegmental cap dysplasia, or pontine duplication aplasia. Now, this is a pontine tegmental cap dysplasia, where you have this cap sitting dorsally to the pons, protruding into the fourth ventricle. The pons is flattened, and you have a hypoplasia of the middle and inferior cerebellar peduncles. You can also have an hypoplasia of the vermis, and typically you have an absence of the inferior olivary prominence. On color code of AMAPs, you have these mal-guided transverse coursing ectopic fibers. You can have additional findings outside of the central nervous system involving the vertebral column, the ribs, or the congenital heart disease. And due to the primarily brainstem involvement, you can have lesions and symptoms secondary to involvement of brain stem, like sensorineuronal hearing loss, facial nerve palsy, trigeminal anesthesia, and swallowing difficulties. And neurocognitive delay may also be observed. So we made it, 10 cases in 15 minutes. Again, thank you very much for your attention, and please be safe and see you next time. Thank you very much.
Hello, everyone from Doha, Qatar. Today, we're going to discuss a few cases of pediatric spine. I have nothing to disclose. So let's start with the first kid. Here we have a 3-year-old kid who was adopted and was noted to have a scar on the lower back. They didn't know what kind of operative intervention he had in the past. We have a sagittal T2, a heavily weighted sagittal T2 3D with coronal reformat. What do you think is the diagnosis? Is it a case of diastomyotomyelia? Is it a case of hydromyelia? Or is it post-operative adhesions and tethered cord? I'm sure you all guessed it correctly. It is indeed diastomyotomyelia. And we can here have the septum within the middle, and we have partial splitting of the cord. Now, I purposely did not put an axial view, but started only with sagittal and coronal to see how it could easily be missed if you don't do axial. People may often overlook it and think of it as mild prominence of the central canal. This is the axillary format of the same patient. You can see beautifully here, 2 hemichord in 2 separate dural sacs. There is a spine lecture given by Dr. Andrea Rossi, and he tells the story of sitting by the TV, watching the news, and there's some sort of protest, and there's a bunch of people running, and he sees a tuft of hair on the lower back of one of them. So he points at the TV and says, that lady has diastomyotomyelia. I learned 2 lessons that day, and that's why I like retelling the story to trainees. One is that a patch of hair on the lower back is one of the birthmarks that hints or equivalent to diastomyotomyelia. The second thing is that she was running, so she didn't have that severe of symptoms. She may even be asymptomatic. In fact, diastomyotomyelia is divided into 2 types, the more severe type 1 and more common type 1, and then type 2. Type 1 is the one where you see the 2 hemichords in 2 separate dural sacs, where type 2, you see the 2 hemichords in a single dural sac. Type 1 is associated with hydromyelia, and it's associated with multiple bony segmentation fusion anomalies and scoliosis. In type 2, you might find the associated bony anomalies, perhaps spina bifida, but not as severe as type 1. Type 1 are often symptomatic, presenting with symptoms of cord tethering and scoliosis, whereas type 2 have less severe symptoms and may even be asymptomatic. Now, let's go back to these birthmark. It's very important to know birthmark. We now know that tuft of hair suggests split cord. If we see a hemangioma, it means it could be anything. If we see a subcutaneous mass, there is a certain differential that you need to know, including lipomyelocele, lipomeningocele, and so on. But what if we see a dermal sinus? So here we have two cases coming to us with a dermal sinus. I immediately ask, where is it? In this kid, we have the dermal sinus in between the gluteal fold. So I know that this is a low-risk patient, unlikely to have an associated dysraphism, and if this sinus continues, it would reach the coccyx. On this kid, however, the dermal sinus is above the gluteal cleft. So this is a higher risk of associated spinal dysraphism, and you may see communication with the thecal sac and increased risk of meningitis. This is a companion case of a dysraphism, and it's just to highlight the importance of ultrasound. We have a 1-month-old with lower back birthmark. This is an ultrasound. We usually try to count the vertebra from top to bottom. If we were to move down, we can see that there's a little bit of promise of the central canal. That's this little bit over here. If we go further down, this is the axial view or the transverse view. You can see cystic serines and dilatation of the cord, which is already very low. And if you go further down, you see the cord adherent to this hyperechoic mass, which we know likely represents a intraspinal lipoma. We do an MRI, it's a SAGT1 and a SAGT2 of the same patient, and we can see a tethered cord with distal serines adherent to an intraspinal lipoma. Again, it's the same patient. If I were just to flip the ultrasound, you can see how well they correspond to one another. Here is the lipoma, and you can see the lipoma down here. You can see the serines also very beautifully. Of course, ultrasound is heavily operator dependent, and you can only utilize it within the first 2 months after birth. Moving on, let's look at the next patient. Here we have a 14-year-old girl with worsening unsteadiness. We have a sagittal T2 weighted images, a post-GAD SAGT1, and an axial post-GAD of the brain. You can note the cystic changes of the cord, and like a cystic serines, taking almost the entire of the cord. Post-contrast administration, you see avid enhancement of these nodules seen, one within the cervical region and one within the lower thoracic region. They weren't very easy to depict on the pre-GAD or on the T2 weighted images. Of the brain, you can see similar enhancing nodules. What do you think is the diagnosis? Is it spinal metastases? Is it von Hippel-Lindau disease? Or is it a spinal ABM? I'm sure most of you got it correctly. It is von Hippel-Lindau disease, and these are all multiple hemangioblastomas. We always learn during residency, if you were to see a cystic mass within the posterior fossa with enhancing nodularity, it's a pilocytic with a differential of hemangioblastoma. But if you see multiple lesions, then it's multiple hemangioblastomas in a case of von Hippel-Lindau disease. Von Hippel-Lindau disease, like other phacomatoses, is due to the inactivation of a tumor suppressor gene, the VHL gene. It usually carries an autosomal dominant inheritance. It has multiple CNS hemangiomas, primarily involving the cerebellum, like we've seen in our case, then spine, and then brainstem. It also presents with retinal hemangioblastoma. It has abdominopelvic manifestation. It involves the kidneys, if you were to see RCC. If it involves adrenal glands, such as pheochromocytoma, pancreatic sister tumors, and liver cysts. This is our patient over here, and you can see the nodule within the cyst, and you can see associated cord edema, cranial and caudal to it, extending all the way to the cervicomedullary junction. Treatment, when in cases of complications, is resection, and this lesion was resected, and you can note immediate collapse of the tumoral cavity and regression of the associated cord edema. Let's move to the next case. Here we have a 3-year-old with ascending weakness. We have a sagittal and axial T2, as well as a post-GAD sagittal and axial T1. What is the diagnosis? Do you think there is a case of tethered cord? Do you think it's a case of Guillain-Barré syndrome, or is it a dermal sinus with an epidural collection? I'm sure you all got this one correctly. This is a case of Guillain-Barré syndrome. you would look at the cauda equina nerve roots and they think, you know what, I think they are thickened, but maybe if you're using a 3T magnet or with the advanced technique, it's easier to look at the nerve roots. But then you give the contrast and there's a striking enhancement of these thickened cauda equina nerve roots. In fact, the history given to us was not a 3-year-old with ascending weakness. The history given to us is usually 3-year-old with priori GBS. The neurologist knows that in cases, the most common cause of acute ascending flaccid paralysis, it's Guillain-Barré. So by history, we kind of know the diagnoses. Guillain-Barré is a form of autoimmune radiculopathy. It's part of the anti-GQ1B IgG antibody syndrome. If you were to do a lumbar puncture, you're going to see increase in protein without pleocytosis. If you happen to image the brain, you may be able to see enhancement of the cranial nerve root, which is an association that further supports the diagnosis of Guillain-Barré. Differential include chronic inflammatory demyelinating polyneuropathy, which has a more chronic course, although to be fair, we cannot really differentiate the acute initial course of the disease from Guillain-Barré. It could be arachnoiditis if this patient had a recent spinal intervention, say. Could be neurosarcoidosis, leptomeningeal carcinomatosis, and lymphoma, although those would have more nodular enhancement, tick-borne diseases such as Lyme, and even rare entities such as hereditary motor sensory neuropathies and Krabbe disease. Now let's look at the next case. Here we have a 1.5-year-old boy with difficulty mobilizing after a fall. We did an APN lateral X-ray, which showed a collapse of T5 with displacement of the paraspinal line, denoting associated paraspinal collection or perhaps a mass. This patient was immediately referred to MRI, where we did a sagittal stir, post-GAT sagittal T1, as well as an axial T2 fat sat and post-GAT T1 fat sat. What do you think is your diagnosis? Here we have evidence of a large paraspinal collection with thick, well-defined enhancing wall. You can see extension of this abscess or collection into the spine with displacement of the cord, which appears stretched. It involved multiple vertebral body, more so anteriorly than posteriorly, giving you a little bit of a, well, not a little bit, quite a bit of a gibbous deformity. The other discs, however, are preserved. Now, before you want to venture a guess, I'll give you one more hint. We did a CT on follow-up of this patient a few days later, and we noted calcification within the collection. This CT was pre-operative planning for drainage. So we noted calcification within the lesion. The diagnosis is Pott's disease, TB spondylitis. Now, a common question that examiners like to ask is, why is it TB spondylitis and not pyogenic? So we have here a companion case, which is a case of pyogenic spondylodiscitis or discitis, and this is the same patient on follow-up with very exaggerated gibbous deformity. So you'll note that the pyogenic spondylodiscitis usually have small or maybe even no paraspinal or intraspinal abscesses, whereas our case of TB spondylitis had a very large paraspinal abscess with an intraspinal component. In pyogenic spondylodiscitis, if there's an abscess, it would be within the disc. In TB, it will be within the vertebral body. In pyogenic spondylodiscitis, there's almost always moderate to complete disc destruction, whereas we don't see that until very late stage within the TB spondylitis. In pyogenic spondylodiscitis, you will see that the bony destruction is minimal and infrequent. However, it is very frequent in TB. You see in this one, it involves 1, 2, 3, 4 vertebral bodies. In pyogenic spondylodiscitis, it's usually 1 or 2 vertebral level involved, whereas it is multiple vertebral level involvement in TB. Finally, pyogenic is more common within the lumbar spine, and TB is more common within the thoracic spine. And if you were to see calcification, that's a big hint of speedy TB spondylitis. Now let's look at a differential. If we have a vertebral plana, what is your differential? There's a mnemonic for it. I MELT. I for infection, M for metastases, E for eosinophilic granuloma, L for lymphoma or leukemia, and T for trauma or tuberculosis. So I'll give you a companion case, and let's figure out which one of these differential is the diagnosis for this kid. This is a 4-year-old girl who comes in with 1 month history of on and off interscapular back pain. And she's found by X-ray to have a vertebra plana and referred to MRI where you see T5 vertebra plana. There's a little bit of signal changes involving T4. The end plate look preserved. The disc here looks preserved, whereas the T4, T5 disc appears a bit narrow. And there's quite a bit of inflammatory enhancement, sparing the posterior elements. So what do you think is the diagnosis? Which one of these would be the diagnosis? Well, you guys are correct. It is indeed eosinophilic granuloma. Langerhans cell histiocytosis is the most common cause of vertebra plana in this age group. And we know, for example, that it's unlikely to be leukemia or lymphoma, given that the bone marrow is normal. We make sure to check the adrenal in these patients to rule out metastases, such as metastatic neuroblastoma. And given the facts that there's preservation of the end plates, you don't see much of a collection, we know that infection and tuberculosis are unlikely. Thank you very much.
Hello, everybody. My name is Amy Giuliano. I'm a head and neck radiologist at Massachusetts Eye and Ear Infirmary and Harvard Medical School in Boston. And I'm also the course director for the case-based review in neuroradiology for RSNA this year. And while I have the stage, so to speak, I would like to thank my fellow speakers in the 2 sessions for agreeing to be faculty this year. For my part, I will talk about pediatric head and neck, lumps that go bump in the night. So let's get started. Here's my first case. Here's a lesion, as you can see on this T2 weighted MRI, on the right side, posterior to the angle of the mandible and anterior to the sternocleidomastoid muscle. So what could this lesion be? Well, we can think about lymph nodes. So here are 3 different patients with neck nodes at level 2, which is at this location. This patient on top has these nodes, and these are normal nodes. Nodes tend to be more full and larger in kids, and that's perfectly normal because they tend to get germy, they get reactive adenopathy. In the middle image on the CT, you can see the nodes are enlarged, but in addition, hazy infiltration. So this is a case of cervical lymphadenitis. In the bottom, this is an enlarged node in the case of a metastatic adenopathy. But all these nodes are still kind of round, as opposed to this lesion in our index case, which is kind of triangular and conforms to the shape of structures around it. Here's a case of a lymphatic malformation. So you can see it's multilobulated septated. Can our case be a lymphatic malformation? Well, we don't see septations, but they don't all have septations. The other thing about it is that this lesion is not that bright on T2, whereas LMs tend to be fairly bright on T2 weighted sequences. Could it be a hemangioma? Well, hemangiomas are true neoplasms, and they are high flow lesions, meaning there tends to be arteries inside, so we can see flow voids on an MR. Our index case here has absolutely no flow voids within. Here's an example of a hemangioma with flow voids. They tend to enhance very avidly, and on an MRA, you can even see some of these feeder arteries. So this does not look good for a hemangioma. What other lesions can happen at the level 2 location? Well, you can have second branchial cleft cysts, but they tend to be round, very well circumscribed, unless infected, in which case you might see some inflammation around it. This is a metastatic node, and this is from a papillary thyroid cancer, so you can see the calcifications. These nodes can be cystic, they can be hyperenhancing. And here's a case of a child with an epidermoid cyst. So this lesion in our index case does not look like any one of these. This patient went on to get an ultrasound, and you can see here this very classic appearance, kind of like a starry sky with these little speckled areas that are echogenic. So this is a case of an ectopic thymus. And the identifying points are that number 1, it's pliable, so it tends to be triangular and conforms to the shape of structures around it. On ultrasound, a starry sky appearance. And then also the location has to be correct, because all embryologic lesions have to conform to embryologic geography. So let's take a look at how the thymus forms. So here is the famous picture depicting the branchial apparatus, and you can see here first, second, third branchial pouch on the inside. This red is the progenitor of the thymus. So this is where this tract starts descending. And this is the thymopharyngeal duct. It comes down the lateral neck, lateral to the thyroid gland, then inferior to the thyroid lower pole, and finally going into the mediastinum. And the two ducts on either side then converge in the midline when the thymus then settles into the mediastinum. Thymic anomalies can arise from either incomplete descent, so everything doesn't go down properly. So you get ectopic thymus or you get a thymic cyst. Or the duct does not involute after all the primordial cells move down. So what you have left is a duct remnant, and you can have cysts develop in there because the lining would secrete fluid. So a thymic lesion would be expected anywhere along the path from the angle of the mandible down towards the sternum, anterior or deep to the sternocleidomastoid muscle. Here is a case of a lesion that goes down along that tract. So it's lateral, posterior to the angle of the mandible, and it goes down lateral to the thyroid gland, and this was a thymopharyngeal duct remnant. Here's another lesion that is inferior to the thyroid lower pole, going down towards the mediastinum. This is a thymic cyst. A lot of them present before age 10, and they may be separate from the thymus or connected by a fibrous band. All right, case 2. Here we have a lesion on the right neck. It is posterolateral to the internal jugular vein, and it's enhancing quite a bit. So what could this be? Well, the location is very good for a lymph node. So here we're basically talking about the differential diagnosis of a hyper-enhancing node. Here's an example of a patient with hyper-enhancing nodes in very much similar location, posterolateral to the internal jugular vein. But notice in this case, it's a bit heterogeneous, and there are also some internal areas that are calcified. This was a 13-year-old with a metastatic papillary thyroid cancer. Our case is much more homogeneous. This patient did go on to have an ultrasound, and you can see the lesion is really quite hypoechoic and a lot of vascularity. And when you see that, you would think about Castleman disease, which was what this ended up being. So the key to Castleman is you see a node that has avid enhancement, hypoechoic on ultrasound, with lots of vascular flow. It's an angiofollicular lymph node hyperplasia, and it's a lymphoproliferative condition that's considered benign, and it's of B-cell origin. So here's another patient. This one has a few nodes that are all pretty hyper-enhancing down the neck. You can have unicentric and multicentric varieties, and the unicentric tends to happen more in children or young adults, often incidentally noted. A lot of the Castleman disease is found in the thorax, so you see mediastinal nodes, but 10 to 15% you can see in the neck. All right, case 3. So here's an ultrasound of the left neck, and I will tell you that this is a 29-day-old infant. This is the contralateral neck, where you can see a structure here that is the normal sternocleidomastoid muscle. Now, could this be a neck mass that is separate from normal structures? Sure, but as we scan on ultrasound up and down, we will find that this lump here is actually inseparable from the sternocleidomastoid muscle. Here is a transverse look, and really you can see it's along the confines of the muscle, sort of along the muscle bundle, but it's just expanded, it's kind of thickened, and when you look on ultrasound, there is quite a bit of flow. This was a case of fibromatosis coli. This is another patient. You can see at left level 3, it's palpable, it presents as a firm mass, and you could very well mistake it for an abnormal mass, like a rhabdomyosarcoma or an abnormal node. And the key really is that it conforms to the course and the shape and the location of the normal sternocleidomastoid muscle. The only problem is that it is too thick. And if these kids go on to get MRI, it can actually be confounding the situation because it can look pretty scary on MR. In this child, you can see on T2 weighted sequence, it's fairly bright, but it follows the geography and the contour of the sternocleidomastoid muscle. These patients tend to have torticollis because this mass is firm, it is a bit retracted, so the chin tends to be tilted away from the side where there is this lesion. So the key points: firm mass, patients presenting with torticollis, conforming to the shape and the location of the sternocleidomastoid muscle. If you see calcifications, that is suggestive of prior hemorrhage. The important thing is to recognize that this is a completely benign entity. There's nothing to do, no need to biopsy. These patients go on to physical therapy, and gradually the conditions should resolve. All right, case 4. So here we see a lesion that is in the region of the submandibular gland, and in fact just anterior to it. Here you can see it continues down, inferior to the floor of mouth with some mass effect. It is quite bright on a T2-weighted sequence. So what could this lesion be? So we're talking about differential diagnosis of a cystic lesion in the submandibular region. Well, here is a patient with a lesion in a very similar location, just anterior to the sternocleidomastoid muscle. This one is multilobulated, septated. You can even see that there is a fluid level. So that is highly suggestive of a lymphatic malformation, which is what this lesion was. Another one, similar location, anterior to the submandibular gland, coming from sort of like the floor of mouth, but it is quite low in density. And the patient did go on to have an MR where on this fat-suppressed sequence, the signal drops out, and this was fatty, and this was a dermoid cyst. Here's another patient. You can see in the submandibular region, lateral and inferior to the floor of mouth, there are these nodules that are soft tissue density, and these are abnormal and large nodes. They could be reactive, could be metastatic. Those are things to consider, but these are lymph nodes. Here's another patient. You can see that here's a lesion that seems like it's in the submandibular region, but there's this thin sliver of soft tissue around it that turned out to be the mylohyoid muscle. So in fact, this abnormal, heterogeneously hypodense lesion is in the sublingual space, and this turned out to be a sublingual gland-related adenoid cystic carcinoma. Our index case is a ranula, so that is cystic, and the giveaway here in this case is that there is a tail that extends through the mylohyoid defect, which is known as the mylohyoid boutonniere. And that's trying to tell you where this lesion originally came from, which is the sublingual space. So the giveaway take-home points: sublingual space or submandibular region. If you see a tail going towards the sublingual gland, that's very helpful. It's trying to tell you where this came from. It is a cystic lesion. And when we do an FNA, we send for amylase because there could be some salivary components in there. And if you see amylase, it would tell you that this is coming from a salivary origin and would tell you that this is a ranula. So there are two varieties of ranulas. There's a simple ranula, that is a mucus retention cyst of the sublingual gland or minor salivary gland in the sublingual space, and it's confined by the mylohyoid muscle, as you can see here. It could arise spontaneously or after trauma or surgery, inflammation, but the key is that this is a true cyst. There's an epithelial lining, and inside it there's mucin. There could be saliva components giving you a positive amylase on FNA. The diving ranula is what we have in our case, and that is when a simple ranula enlarges and it ruptures. The mucus extravasates, and it can go through weak spots, such as a mylohyoid defect. It can go around the back of the mylohyoid towards the submandibular region. And this, because it's ruptured, is in fact a pseudocyst. So now it's extravasated mucus that then gets confined by a lining that is not the true epithelial lining. All right, my final case, case 5. So I wanted to show this because this comes up very, not very frequently, but not infrequently. So this would be a child, usually under the age of 5, maybe even younger, with a palpable neck mass, usually anterior neck. So we tend to start with an ultrasound because if it's palpable, if it's a pediatric lesion, ultrasound is really very helpful. And here's a lesion. And this is done with Doppler, and you can see there is no flow inside. And there are these little tiny echogenic foci, and that's very pathognomonic. This child did go on to get a CT, but you in fact don't really need to go on to get a CT. And you can see here's an anterior midline neck mass that is quite hypodense, looking pretty cystic. And this was a dermoid. So the key points here are that midline or near midline, either cystic looking, or if it's not cystic, there might be some complex internal debris and material, but no flow, meaning it's not a solid neoplastic mass. And if you see fat inside, such as these echogenic foci, maybe fatty components, that really tips you off that it's a dermoid. Here are additional cases, another patient with these fat globules. They suppress on a fat suppressed MR sequence, another one in the midline floor of mouth. These tend to be well circumscribed, unilocular, usually midline. Ultrasound may be echogenic. On CT, may contain fat globules. On MR, you may see fat components. There are ectoderm-lined inclusion cysts when there is persistence of ectodermal elements at suture closure and nerve tube closure sites. If it's squamous epithelium, it's epidermoid, plus some skin elements, there may be fatty components, that would be a dermoid. That's it. Thank you so much for your attention, and I hope you enjoy the rest of the conference.
Hello, my name is Carlos Torres. I'm a neuroradiologist and professor of radiology at the University of Ottawa in Canada. I would like to thank Dr. Giuliano and the organizing committee for the invitation. In the next 15 minutes, we'll review some interesting and challenging cases. I have no disclosures. The first case is a young male patient who happens to be a wrestler by profession who presented to the ED in 2014 after hitting his head on the mat during a match. He presented with headache and temporary peripheral vision limitations that resolved spontaneously. This is the head CT that was performed on admission. In the ED, we can see that there is a large hypodense lobulated extraaxial lesion centered in the right frontal parietal region. That lesion demonstrates focal areas of increased density suggestive of acute bleed. This lesion also demonstrates a septation towards the posterior aspect of the lesion. So we come up with a list of differential diagnoses. Could this be a chronic subdural hematoma with superimposed acute hemorrhage, or an arachnoid cyst with superimposed acute hemorrhage? Could this be a dermoid or an epidermoid cyst, or something such as a cystic metastatic deposit? The following day, an MRI was performed that shows again this lobulated extraaxial lesion that follows CSF signal on T2. However, note that the signal is not the same as CSF on FLAIR. Again, on the sagittal T1, we can appreciate that there is a focal area of increased signal intensity suggestive of blood products in the dependent portion of the lesion, which is confirmed by a blooming artifact in the gradient echo sequence. Importantly, there was no restricted diffusion, no mass lesion, or abnormal enhancement. What I mean by no mass lesion is no solid component or abnormal enhancement. So again, we discuss the same differential diagnosis. At this point, the patient was no longer symptomatic and neurosurgery decides not to intervene and to follow up conservatively. This is the follow-up imaging performed 1 year later, where we see that the lesion has decreased in size and changed in imaging characteristics. There is now increased density on CT, low signal on T2, and increased signal intensity on T1 weighted sequences. At this point in time, the patient is lost to follow-up and only comes back to the hospital 3 years later. Comes back because now presents with headache and seizures, and this is the new MRI that is performed at that time in 2018. We can appreciate that the lobulated lesion has increased in size once more, and again we see focal areas of increased signal intensity on the T1 pre and post gadolinium sequences. So this is the progression of the lesion at presentation in 2014, 1 year later, where we saw the decrease in size and change in signal characteristics, and then in 2018 when the lesion went back to the original size. So again, what is the most likely diagnosis? Are we dealing with some sort of subdural hematoma, arachnoid cyst, epidermoid cyst, a cystic metastasis, or is this something different? Given the patient's symptoms of seizures and headache, at this point in time, neurosurgery decided to take the patient to the OR, and pathology demonstrated that this actually was a neuroenteric cyst. So this is a supratentorial neuroenteric cyst. So neuroenteric or enterogenous cysts are rare benign endodermal lesions of the central nervous system. They are more common in the spine and in the posterior fossa. Actually, they are 3 times more common in the cervical spine. When supratentorial in location, they tend to be located in the frontal regions. As we've seen in this case, they do not follow CSF signal on FLAIR, which is helpful to make the difference with arachnoid cysts, and they do not show restricted diffusion, which is also helpful to differentiate them from dermoid and epidermoid cysts. This is the next case. This is a patient who presented with headache and multiple cranial nerve abnormalities, and we can appreciate in these axial FLAIR images that there are multiple patchy lesions of increased signal intensity in both cerebellar hemispheres, in the bilateral brachium pontis, in the posterior limb of the right internal capsule, head of the right caudate nucleus, splenium, and body of the corpus callosum. So as usual, we come up with our list of differential diagnoses. Could this be demyelinating disease, such as multiple sclerosis? Could this be some sort of vasculitis, an infectious process, or ADEM? And the answer is infection. But what type of infection can lead to this type of findings? And the answer is Lyme disease. Lyme disease can give us this type of imaging abnormality. So Lyme disease is a bacterial infection caused by the Spirochete Borrelia burgdorferi, which is transmitted to humans through the bite of infected blackleg ticks. There are approximately 20,000 new cases reported each year in the US, and therefore Lyme disease has become the most common vector-borne disease in that country. It has a prevalence that is more important in the mid-Atlantic states, as well as in Michigan, Wisconsin, and Minnesota. And you can see that there is also increased prevalence in Europe and in certain parts of Asia. This disease is also more common during the summer, and transmission of the spirochete requires at least 1 to 2 days of tick attachment, and the responsible for the disease is this nymphal tick. In terms of the clinical presentation, usually patients will present with flu-like symptoms such as headache, fever, malaise, myalgias. A proportion of patients can present also with erythema migrans, which tends to be quite characteristic. We have this target type appearance of these lesions that actually represents the centrifugal spread of the spirochetes through the lymphatics of the skin. If the patients are not treated, then they will develop cardiac and neurologic abnormalities, as well as migrating pain in joints and muscles. And again, if no treatment is given, this progresses to chronic mono and oligoarticular arthritis of the large joints. Okay, let's move on to the next case. This is an interesting case of a young male patient who happens to be a nurse. This patient was taking his first surf lesson in the south of Spain, and then after coming out of the water presented with back pain and bilateral leg pain, which 2 hours later progressed to paraparesis, and then he was no longer able to walk. So the patient was immediately transferred to the hospital. An MRI was performed, and we can see that there is abnormal signal intensity along the ventral aspect of the mid-thoracic cord and conus. These axial images are obtained at the level of the conus, and we see the signal abnormality in the center of the spinal cord. After gadolinium administration, we can see that there is enhancement along the ventral aspect of the cord, more specifically involving the ventral horns of the gray matter. So as usual, we come up with our list of differential diagnoses. Could this be some sort of longitudinally extensive transverse myelitis, a dura-levi fistula, a spinal cord infarct, or some sort of myelitis? And the answer is Surface myelopathy. So what is surface myelopathy? Well, it's a rare form of spinal cord ischemia that affects young, healthy, novice surfers. So these are people who have never surfed before and who do not have any pre-existing spine disease. It's supposed to be the result of a vascular phenomenon that is a combination of dynamic compression, vasospasm, and thrombotic infarction of the anterior spinal artery due to prolonged hyperextension in the prone position over the surfboard. And apparently the thoracic cord is at higher risk due to poor collateral vascular supply. This is the follow-up MRI of this patient 1 week later, where we can appreciate that there has been complete interval resolution of the T2 signal abnormality. Actually, the patient did well clinically as well, but that is not always the case. This is a nice systematic review published in 2016 in Neurosurgery, where they reviewed the 64 cases that had been published up until then, and they noticed that only 42% of those patients had had complete neurological recovery. And this is the last case. This is a patient who presented with pain in the left chest wall and generalized low back pain. This is the CT scan of the thoracic spine that shows that there is a calcified lesion within the spinal canal. It is not clear if it's intra or extradural in location. Of note, there's also a significant sclerosis of the posterior aspect of the adjacent vertebral body, but there is no bone destruction nor expansion of the spinal canal. So as usual, we come up with a list of differential diagnoses. Could this be a calcified meningioma, calcified disc herniation, Cavnon, a tuberculoma, or a paraganglioma? So an MRI was performed. We see that the lesion is a very low signal intensity on T1 and T2 and shows avid post-gadolinium enhancement. The lesion is clearly extramedullary in location, and this is the summary of the images on CT and MRI. And again, these are the most likely the potential differential diagnosis that we can come up with. And the actual answer to this case is Cavnon. So what is Cavnon? So this is known as calcifying pseudoneoplasm of the neural axis, which is a rare entity also known as a fibro-osseous lesion of the nervous system. It has no predilection for age, sex, or CNS location, so this entity can be seen in the brain as well. The lesions could be intra or extra-axial, but they tend to be located along the ventrolateral epidural space more commonly. They grow very slowly, so symptoms are usually related to compression of the cord or cauda equina. The underlying cause remains unknown, but they seem to develop as a healing response to any inciting factor such as trauma, infection, or inflammation. At the end of the day, these are non-neoplastic lesions. And here's a companion case of a patient who presented with a cord compression, and we see that there is a calcified lesion within the spinal canal. The MRI of this patient shows that the lesion was larger than we expected. Again, this seems to be a dural-based lesion, and indeed we see that there is avid post-gadolinium enhancement and a dural tail in keeping with a meningioma. So a low percentage of these lesions may calcify. Actually, less than 5% of spine meningiomas will calcify, such as in this example of a dorsal meningioma at the level of C7, causing some degree of cord compression. But that calcification is important to know, and that finding needs to be conveyed to the neurosurgeon, given these calcified meningiomas are usually associated with adhesions to the cord, and that may increase the morbidity of the surgery when the lesion is removed. So this was the last case. I hope that you like the cases and the whole session, and that you're enjoying the meeting. Thank you.